Welcome to our online conference today. Before giving the floor to our dear guests, I want to introduce our team. I will be the moderator of today's conference. My name is Nurullah Kösmene. I am one of the residents of the Neurosurgery Department of İzmir Training and Research Hospital. These online education meetings have started with Associate Professor Hasan Kamil Sucu, the Program Manager of the Neurosurgery Department of İzmir Training and Research Hospital, and goes on with the contributions of all the residents. Also with the contributions of the neurosurgeons who graduated from the same department. I kindly ask you to keep your microphones turned off during the presentation of the lecturer to avoid voice and noise pollution. You can ask your questions not by opening your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please do not ask your microphone to be turned on. And now I would like to introduce our dear guest. It is my privilege to present our lecturer, Professor Kawaguchi Yoshiharu.
Thank you.
Mr. Yoshiharu was born in Toyama, in Japan, in 1962. He graduated from the Faculty of Medicine, Toyama Medical and Pharmaceutical University in 1988. Mr. Yoshiharu did his residency at the Department of Orthopaedic Surgery, Toyama Medical and Pharmaceutical University in 1988 and in 1989. After that, he continued his residency training at Nagano Prefecture Suzaka Hospital. He studied as a PhD student at the postgraduate school of Toyama Medical and Pharmaceutical University in 1990 and 1994. In March 1994, he was awarded the degree of PhD. He continued his studies as an assistant professor at the same university in 1994 and 1997. Furthermore, between October 1994 and August 1995, he worked with Professor Björn Ridevik at the University of Gothenburg, Sweden, as a research fellow. In 1997, he became a lecturer at the Department of Orthopaedic Surgery in Toyama Medical and Pharmaceutical University until 2004. In 2005, the name of Toyama Medical and Pharmaceutical University was changed to the University of Toyama. In 2008 and 2009, he studied as an associate professor at the Department of Orthopaedic Surgery, University of Toyama. In 2009, Mr. Yoshiharu became a clinical professor at the same department. And till 2019, he continues his studies as professor and chairman of the Department of Orthopaedic Surgery of University of Toyama. His major interests are spine surgery, muscle pathology, electrophysiology, molecular biology, lumbar disc disease, spinal stenosis, myelopathy, and ossification of the posterior longitudinal ligament. He has many memberships of academic societies and he has many awards for his studies. Professor Yoshiharu is the author of more than 100 international articles. Today, Professor Yoshiharu will give a speech about ossification of the posterior longitudinal ligament to us. Welcome again, Professor. Now you can start sharing your screen, please.
Thank you very much, Mr. Chairman. Can I start?
Yes, you can start. Thank you.
Thank you very much. It's a very great honor for me to present the paper to the meeting. Today, my talk is ossification of the posterior longitudinal ligament, OPLL, pathology and treatment. I am working at the Department of Orthopedic Surgery, University of Toyama, Japan. The Toyama means richer mountains. You can see behind me, the mountains. The mountain's height is more than 3,000 meters. So we call Japan Alps. So I was the chairman of the committee for the development of clinical practice guidelines for ossification of spinal ligaments in Japan. So now we start. This is my profile. I am a chairman of Eospine Asia-Pacific region, education chair also. And I have nothing to disclose for my presentation. Today, my talk is 2 parts. Part 1, pathophysiology and background factors of OPLL. The second part is therapeutic strategy for OPLL. Now I will start first one. This is OPLL, ossification of the posterior longitudinal ligament. You can see ectopic bone formation in the spinal canal. Spinal canal narrows due to OPLL, and spinal cord compression occurs at cervical spine. So it causes cervical myopathy and as well as radiculopathy. The textbook about OPLL were published from spring 2006 and 2020, the OPLL second edition and third edition. And the guideline for ossification of the spinal ligament was published in 2019. These are the members of for the guideline. This guideline is written in Japanese, but fortunately, the English version was published in Journal of Orthopaedic Science 2021 this year. So please consult this guideline if you want. The guideline consists of 8 chapters, including OPLL and OLF. OLF means ossification of the ligamentum flavum. OLF is predominant in thoracic spine. In the OPLL is predominant in the cervical spine. As for the OPLL, the pathophysiology is unknown. OPLL is predominant in male versus female, 2 versus 1. And we, Asian region, have a lot of patients with OPLL. In Japan, the incidence of OPL was 3%, and it was 3.6% in Korea, and in China, 1.1 to 1.7%. In contrast, US, 0.12%, in Germany, 0.1%. This OPL is frequently seen in Asians compared to Caucasians. Asian percent 4.8%, Caucasians 1.3%. OPL is frequently seen in the cervical spine, like this. But it is also found at thoracic and lumbar spine. This 73-year-old female had OPL not only in the cervical spine, but also in the thoracic and the lumbar spine. This 63-year-old male had OPLL in the cervical spine, and also he had OLF, ossification of ligamentum flavum, at the thoracic and the lumbar spine. We have reported that more than half of the patients had multi-level OPLL. CT group means cervical thoracic group. CL, cervical lumbar, cervical thoracic lumbar group. So more than half patient had multi-level OPLL. And 60%, more than 60% of patients with cervical OPL had OLF at the thoracic spine. Therefore, if you see the patient with OPLL in the cervical spine, you must check for the spine. We investigated the indicator which shows the existence of OPLL in the whole spine. That is OS index. If the OPLL exists here, C4 plus, C45, C5, and C56 means OS index is 4 in this patient. Therefore, possible OS index range from 1 to 14 in the cervical spine, 0 to 24 in the thoracic spine, and 0 to 11 in the lumbar spine. This graph shows OS index, the patient number. Blue is male, red is female. You can see male is predominant in a patient with OPLL. However, importantly, the patient which had OS index more than 20, this is severe OPLL, were all female. Gender is an important factor for the pathogenesis of OPLL. Regarding recent researches for pathogenesis of OPLL were two ways. One is genetic approach, and the other is researches using biomarkers. In the guideline, background question 4, which genes, proteins, and biomarkers are associated with OPLL? The statement or genetic factors are involved in OPLL. Some proteins might be involved for the pathogenesis in OPLL. Also, it has been reported that biomarkers involved in OPLL, including bone metabolic markers, this is not conclusive. That is a statement. In genetic approach, 6 susceptibility genes for OPL were identified in whole genome study, GBES. This study was carried out by Committee for a study of ossification of spinal ligament in Japan. The paper was published in Nature Genetics 2014. Among these genes, functional analysis of RSPO2, responding, is ongoing. RSPO2 control Brent-catenin signal. This inhibits chondrocyte formation, which results in enchondral ossification in OPLL. However, when this signal decreases, inhibition will decrease, and this condition starts initiation of ossification. As for the biomarkers of ossification of spinal ligaments, we have published a review paper. We performed case control study using 103 cases with OPLL and 96 controls. We also check the progression of OPLL in patients which CT images were taken twice at more than 5 years follow-up. This is a big case, 68-year-old male. He had OPLL progression in 10 years. As a result, hypersensitive CRP as well as ESR in OPL was higher than those in control. This suggests inflammation might be a key factor for the pathogenesis of OPLL. Interestingly, we found positive correlation between HSCRP, hypersensitive CRP, and progression speed of OPLL per year. OPLL progression might be associated by local inflammation. Further, serum phosphate was lower in OPLL compared to the control. Negative correlation between serum phosphate and OS index, the extent of OPLL in the whole spine. In addition, FGF23 was higher in OPLL compared to control. Therefore, OPLL increases FGF23, and this might result in decrease of serum phosphate. Very recently, we had the data that periostin, which is a bone metabolic marker, was higher in OPLL group compared to control. And also OPL progression group compared to non-progression group. This might be a key biomarker for OPLL. So we must emphasize that several candidate biomarkers have been identified. Bone metabolic marker, phosphate, FGF23, hypersensitive CRP, and periostin. So in conclusion, in the recent findings for the pathology and background factors of OPLL, pathophysiology of OPLL has not been fully investigated yet. Several candidate genes have been identified. The analysis using biomarkers has been ongoing. Based on these results, therapeutic strategy for the formation and progression of OPLL must be considered in near future. That is in the second part, therapeutic strategy for OPLL. Unfortunately, any conservative treatments are effective for OPLL. Thus, we usually perform surgery in patients with OPLL. As for the surgical indication, surgical decompression is performed for the patient with gait disturbance and clumsiness of hand. It means myopathy and or radiculopathy. And these myopathy and radiculopathy causes disability of daily living. We must consider surgical decompression. However, it is not recommended for neck pain because the surgery itself is not effective for reducing neck pain. This is a case 47-year-old female. She had C6 myopathy. You can see OPLL from C2 to C6. We performed C3 to 7 laminoplasty. You can see widening of spinal canal after laminoplasty. Our method of laminoplasty is unblocked laminoplasty, which was developed by Ito and Tsuji in 1981. That is the unilateral type. This is an open side. This is a hinge side. We used to use bone graft from spinous process and put the bone graft at C3, 5, 7 levels. And spinal canal enlarged like this by rotated lamina. And this is operative view and during surgery. we used to use spinous process to keep rotated lamina. This is duramadder. So we recently use HA block, hydroxyapatite block, to keep the rotated lamina, and decompression is achieved. As for long-term follow-up, we used to publish one paper, which is published in Clinical Orthopaedic and Related Research in 2003. The title was Minimum 10-Year Follow-Up After Unblocked Cervical Laminoplasty. And in 2016, we published one paper, more than 20 years follow-up after unblocked cervical laminoplasty was from Spine journal. I will explain about the 20-year follow-up results of laminoplasty. Material method, 216 patients who had unblocked laminoplasty from 1981 to 1994 for treatment of cervical spondylotic myopathy and OPLL. Male was 154 patients and female was 62 patients. Average age at operation was 51.7 years old. Average follow-up length, 25.5 years. And this is a demographic data of 216 patients. 68 were survived. However, 80 was dead. So we could not reach the 68 patient. So the follow-up rate was 68 plus 80, 148. Follow-up rate was 68.5%. This was, I think, is good for more than 20-year follow-up. Results. This is a time course of a JLS score. You know the JLS score. So JLS score, the full mark was 17 points. So the JLS score increased just after surgery, and it maintained more than 10 years. However, more than 20 years, it decreases. So this is the cause of the decrease patient deterioration cases with decreasing JLS score more than 2 points. So you can see we have 10 patients. So out of 10 patients, 9 patients was OPLL. And they have reoperation 10 to 30 years after laminoplasty. And the surgery was performed for other spinal regions. This is a case, 46-year-old female with OPLL here, pre-op, 1 year post-op, 5 years, 16 years, 28 years. You can see ectopic bone formation at C2-3 level. The CD shows C1 ossification and C2-3 levels posterior ossification occurred 30 years after cervical laminoplasty. You can see cold compression at upper cervical region. Thus, we performed C1-3 laminectomy for this patient. The surgery was really effective. She recovered very much. This is a case, 52-year-old male with mixed type of OPLL, pre-op, and 20 years post-op. So you can see the spinal alignment became kyphotic. However, the problem is not kyphotic deformity. This is the problem at T1-2 level. T1-2 level, OPL progression occurs and spinal canal first narrow due to the progression of OPLL. So spinal cord compression again at T1-2 level. So we performed T1-2 laminectomy in this patient. So through this case, we notice to take care of OPL progression after laminoplasty. This is 44-year-old male, pre-op 11 years after laminoplasty. You can see progression of OPLL at C3-4 level. So cold compression occurred again. So we must perform this posterior decompression again in this patient. So to seek the OPL progression, how does the ossification of OPLL progress after cervical laminoplasty? We published 2 papers, 2006. This is about longitudinal progression. 2007, this is about axial progression. In this paper, we use OPL Draw, the software, to check the OPL progression. This software easily detects the progression of OPLL. This is a result. This is age at operation, and longitudinal axis means progression of the ossification of OPLL. Red group, group 1, 40s at surgery with continuous or mixed type OPLL, rapidly progress after surgery. Group 2, blue line, over 50s at operation with continuous or mixed type of OPLL is slowly progress, but you can see the progression of OPLL in this group. However, group 3, green line, this is segmental type. It's very rare to progress the operation or progression of OPLL. So we think the continuous or mixed type OPLL is different from segmental type. These 2 categories are different, might be different. So we published 1 paper, clinical impact of ossification of the posterior longitudinal ligament progression after cervical laminoplasty. So in this study, 9 patients out of 167 patients underwent the second surgery for neurological degeneration due to OPL progression after cervical laminoplasty. The incidence was 5.4%. This is a case, 58-year-old male, mixed type of OPLL. You can see this is pre-op. This is 3 to 6 laminoplasty and 6 years after laminoplasty. You can see the progression of OPLL 6 years after laminoplasty. And this is MRI. The pre-op just after laminoplasty, 6 years after laminoplasty. You can see the reserve space in the anterior part just after cervical laminoplasty. However, it compressed the spinal cord again 6 years after laminoplasty. Thus, we performed 3 to 6 ACDF in this patient. You can see reserve space after ACDF. This is 60-year-old male with mixed type of OPLL. He had OPL progression at C3 to 4 level. So we performed ACDF in this patient. So posterior fusion has the effect of reducing OPL growth rate compared with laminoplasty. Thus, fusion surgery might be prevent the OPL progression. Ota et al. Said he compared posterior decompression surgery and laminoplasty. the progression of OPL thickness. So the laminoplasty is frequently progress of OPL thickness after surgery. However, the graphs demonstrated that PDF, posterior decompression fusion, reduce the progression of thickness, of OPL thickness. But Lee et al. Has same result. Laminectomy fusion compared to laminoplasty reduces volume of OPL progression after surgery. However, the paper, the one paper which was published Global Spine Journal 2016, this is a systematic review. OPL progression evidence summary. The statement was the overall strength of evidence evaluating the incidence of OPL progression following laminoplasty or laminectomy fusion does not establish the beneficence of one procedure over the other. Therefore, the issue is not controversial, not established yet, and this is controversial. Anterior surgery versus posterior surgery. What do you think for the patient with OPLL? Dr. Iwasaki said OPL penetration in the spinal canal more than 60%. Anterior surgery is better than posterior surgery. Dr. Suda stated that the patient with local kyphosis exceeding 13 degrees require anterior decompression or correction of kyphosis in addition to posterior decompression. Kyphotic deformity like this, exceeding 13 degrees, might not be posterior decompression might not be effective for the spinal cord. So this paper is very famous. The K-line. When the K-line attached OPLL in this patient, like this patient, the posterior decompression itself is not effective. So our strategy of the surgery for the patient with the OPLL, cervical compression, more than 3 levels, posterior decompression is indicated. 1 or 2 levels, K-line minus. We know this anterior decompression is better than posterior decompression. As for the severe cold compression cases, we perform posterior decompression at the first stage, and anterior surgery will be performed at the second stage. Or posterior decompression with corrective fusion might be performed. This is the case, 60-year-old female, GLS score 8. You can see OPLL at C5-6 level. Occupying ratio 70%, very high, and K-line minus. So posterior decompression itself is not effective for this patient. So cold compression is very severe. We perform cervical laminoplasty, and their score recovered from 8 to 12 in this patient. However, they still have compressive factor at anterior side due to OPLL in this patient. So we performed corpectomy from C4 to C6. So JR score improved from 12 to 16. This was very effective. This is 50-year-old female, C6 myopathy. You can see very severe OPLL, and cold compression is very severe. We perform C2 to 7 posterior decompression fusion at first, and then we performed ACDF from C3 to 7. The posterior anterior decompression is very, very effective for this patient. This is a patient with the 82-year-old female. She had very severe ossification at T2-3 level, and cold compression is very severe. So we performed in this patient boson decompression at the first stage and second stage. Sternal splitting approach anterior decompression was performed. This is sternum, and this is cranial, this is caudal. We perform the approach anterior side, T2 body and T3 body, and decompression anterior. You can see dura mater and arachnoid. The sternal splitting approaches was very effective. In this patient, 70-year-old female, thoracic myopathy, very severe cold compression at T3-4 due to the big type of OPLL. So very severe cold compression here. So we performed the posterior decompression fusion at the first stage, and then we performed anterior decompression by sternal splitting approach. The procedure was very effective for this patient. However, this patient, 49-year-old male with OPLL, we performed C2 dome laminectomy plus C3 to 7 laminoplasty. You can see posterior decompression is very defective. However, this patient has very severe cold compression. So we performed C3 to 6 ACDF in this patient. However, this patient had recall discharge during the anterior surgery. So we performed lumbar drainage, 500 milliliters per day for 5 days. Recall was successfully healed. The anterior surgery is technically demanding, and complication might be occurred, and such as recall and dislodgement of the cage. So we must be very careful for performing anterior surgery. This 60-year-old female, cervical myopathy due to OPL. This is neutral flexion and extension. You can see cold compression at C3-4 level and C5-6 level. The alignment was really bad in this patient. So low-rudo kyphotic alignment she had, and very small OPLL at C6 region. We performed posterior decompression and fusion using pedicle screw from C4 to 7. The pedicle screw is nicely placed from C4, 5, 6, and 7. So the alignment became lodokyphotic to straight. And this decompression is achieved very successfully in this patient. So to insert a pedicle screw in the cervical spine, lower cervical spine, it is very dangerous. So therefore, we used 3D bone model and mold like this. The mold attached to the surface of 3D bone model, and by using CT scan. So we pre-operatory had surgical planning using to determine the direction and length of screw in the cervical spine. So we made surgical planning before surgery, and all the screws are performed successfully in this surgical plan. And we will do the surgical planning using the CT scan. And thereafter, during surgery, we used the guide, the mold, to attach the surface of the lamina and insert a pedicle screw very safely like this. This is recent progress for the cervical spine surgery in our team. This is the last slide. OPLL, ossification of the spinal ligament. Pathophysiology is unknown. We research the genetic research and as well as bone metabolic markers and biomarkers to notice the pathophysiology for OPLL, but it is still unknown. Conservative treatment is not effective. So there is no effective conservative treatments right now to improve the cervical myopathy due to OPLL. That is a problem. And lastly, surgical method. We performed a lot of cases of surgical method. However, the surgical method should be considered according to the global spinal alignment and local characteristics of OPLL. And I would like to emphasize we must take care of the OPLL progression after surgery. Thank you very much for your attention.
Thank you, sir. It was amazing lecture. I have questions for en-block laminoplasty. You perform en-block laminoplasty. For these patients, do you recommend cervical color for stabilization after surgery? How months or how days?
Thank you very much. I think cervical laminoplasty is motion preserving surgery. Thus, we cannot apply any rigid orthosis after surgery. Just we use color and recommend that we recommend a patient to move the cervical spine as much as possible just after surgery.
Okay, sir. Thank you. And I have one more question. Do you perform facetectomy when correcting cervical kyphosis with pedicle screws?
Yeah, sometimes in patients with severe osteoarthritis in the cervical spine, we usually perform facetectomy in this patient. However, if you notice the range of motion is good in patient with OPLL, you cannot do the facetectomy in this patient. You can if you get very strict anchor, such as pedicle screw anchor in the cervical spine, you cannot do. You do not have to do the facetectomy. You can correct the cervical spine alignment using pedicle screw placement.
Okay, thank you, sir. We have more questions in chat part. Dr. Kamil Sucu, he says, thank you for this great and enlightening lecture. Is progression of the OPLL due to movement? Can stabilization with lateral mass screws, etc., prevent from progression completely?
Yeah, thank you very much. As I said in the lecture, that is controversial still. But I think the OPLL progression, the motion will enhance OPLL progression. That means to fuse the cervical spine might be effective to reduce OPLL progression. So we perform. Usually, the very severe case will do the fusion surgery as well.
Yes, thank you, sir. He has one more question. He says, I think that preserving the spinous processes and supraspinous ligament while performing laminoplasty will protect and even increase the lordosis. What is your observation on this matter?
Pardon me again, please, question.
He says, I think that preserving the spinous process and supraspinous ligament while performing laminoplasty will protect and even increase the lordosis. What is your observation on this matter?
Thank you very much. We always cut the spinous process in our procedure. So most of the case, seeing the spinal alignment after laminoplasty and block laminoplasty, most of the patient became kyphotic. That is one of the problem, I think. So if you do not want to the patient, the alignment became kyphotic, you must do fusion surgery.
Yes, thank you, sir. I don't see any other question. Sir Kamil Sucu, do you have any words?
I want to thank you again, Professor Kawaguchi, for accepting our offer to give us a lecture. Thank you so much. It was a great honor for us. Thank you. I hope we can see in Turkey in 2022 September.
Thank you very much. I'll do that. I definitely want to go.
Thank you.
Thank you.
Okay. Another thanks, Nurullah.
Yes, Dr. Alaaddin Bayrak, who is a resident in our clinic. Thank you very much for excellent presentation. He says, how many degrees of angle correction can you make in cervical kyphosis? What is the risk of motor deficit?
Yeah. If you use pedicle screw in the cervical spine, the alignment, cervical alignment will kyphotic to straight, not lordotic. So that is a problem. So straight is a maximum usually.
Yes, okay, thank you, sir. There is no other comments or question. Thank you, sir.
Thank you very much.
We are very
Thank you.
happy to this lecture. Alim Can Baymur says thank you very much for your lecture. He says to you. Okay, thank you.
Thank you very much.
Thank you everyone to join. Thank you.
Bye-bye.
Okay, bye.